think about those really big numbers. Think about your clinic caseload. So if you are seeing any female over the age of 50, the odds of her just, sat in the waiting room, nothing else about her, the odds of her having osteoporosis is nearly a quarter. So really high levels of low bone density. And that would track with the number of fragility fractures that we're seeing. So why do we want to suspect you'll notice on a couple of these slides, embarrassingly, I've spelled vertebral wrong, which is irking me significantly, but I haven't had time to change it since I just noticed. But suspecting vertebral fractures, why do we want to suspect these vertebral fractures? Well, there's a few different reasons. It's nice to have a diagnostic accuracy for symptoms. We live in a period of arguably physiotherapy, but other healthcare professionals as well, where we are trying to move away from a purely structural cause for symptoms. Some would argue that pendulum, use that phrase, is swinging too far. Others would argue it's not swinging far enough. I think the answer is somewhere in the middle. Sometimes we are under-diagnosing, sometimes we are over-diagnosing structural issues, and certainly in the reason we're doing this presentation now is that we are under-diagnosing vertebral fractures, insufficiency fractures. So it's a good diagnostic accuracy for symptoms. Now, apart from that, doing your patient a good service, it is really important marker of identifying bone health. So one of the big issues that we see is this multiple fragility fractures occurring.